Thank you to the audience to be persistent until the end of this meeting, and we still have a great talk afterwards. I will focus a little bit on some of the main aspects related with some of the guidelines that were produced by the ESC and some recent data also on, and I will be a little bit more than just prosthetic heart valves and go into valve disease in pregnancy. These were the guidelines that were produced in 2011 by the ESC regarding cardiovascular disease during pregnancy, and there was a whole section dedicated to valvular heart disease, including prosthetic heart valves. And there is also an interesting paper that was published just a few months ago, and that was headed by Karen Sliva, colleague from South Africa, that actually made a very nice review on the management of valve disease in pregnancy, a global perspective, including some specific adaptation to low-income and middle-income and high-income countries, which might be interesting. I will not get into the details, but it's an interesting perspective that I recommend. Well, regarding the background of valve disease or actually in terms of pregnancy, what it means, we know that in Europe, and this is data coming from Europe, 1% of pregnancies are complicated by heart disease. And if we look at the overall death rates per million maternities according with the different types of conditions, cardiac disease represents one of the main reasons for death rate during pregnancy, and it still represents quite a significant load. And some of the other conditions that can lead to little complications also involve the cardiovascular system, such as preeclampsia in a way and VTE. If we look at the evolution of maternal mortality from heart disease in the UK, it's actually quite bad, the figure, and this has to do also with the increased number of pregnancies, of course, but also the increased prevalence of the disease, which makes it, and also the complexity of some of these disease processes that make it still an important condition that needs to be approached correctly. We see here different series coming from different parts of the world in terms of the etiology of cardiac disease in pregnancy. For the acquired disease, rheumatic still represents a very important component, particularly in some parts of the globe. We have also degenerative disease, congenital valvular heart disease, and we can see overall the mortality and morbidity related with these conditions. If we look at the hemodynamic changes that occur during pregnancy, they can actually explain a little bit why, for instance, aortic or mitral regurgitation, so meaning volume-loaded overload conditions, are better tolerated during pregnancy than stenosis, like mitral stenosis or aortic stenosis, and also that can condition a little bit the strategy that should be followed in these patients. Well, basically there is an increase in the blood volume about 50% during pregnancy. There's an increase in the cardiac output by 30–50%, and the maximum of the increase is between the 5th and the 8th month of pregnancy. There is usually a decrease in systolic and diastolic blood pressure and a decrease in the systemic arterial resistance due to different factors, hormonal factors, placenta, and so on. If we look at the changes that occur hemodynamically during delivery, during labor, and postpartum, they can also explain why some of the main complications or some of the main symptoms occur during this period, particularly during the labor period, because there is an increase in oxygen consumption, there is an increase in the baseline cardiac output, as well as blood pressure during the uterine contractions, which again, it will be depending on the modalities of delivery, the type of anesthetic that is used, the fact that it is a C-section or normal labor, and so on. And in the postpartum, there is a shift of blood from the placenta, and therefore there's an increase in preload and cardiac output, which is also observed in the immediate postpartum period. Now, regarding cardiovascular diagnosis, and particularly this is overall, but particularly for the patient with heart valve disease, it's important, of course, the clinical assessment, and then some imaging modalities that should be radiation-free, like ECG, echo, and magnetic resonance. And it can actually be, in certain instances, also used exercise testing, particularly in the setting of some conditions that it might prove to be important for diagnostic purposes. Here it shows that it's important, particularly if it's a planned pregnancy and if there is valvular heart disease already known in the patient. The planning is very important, as in many other clinical conditions, and these are the recommendations for preconception, evaluation and planning of the patient with heart disease, with heart valve disease. A careful history, the ECG, echo, should be considered an exercise test to consider the assessment, to have a better objective assessment of functional classification, and of course careful counseling, which should be done with the patient regarding all the risks involved with pregnancy, particularly in some specific types of valve disease. Complications related with pregnancy, infective endocarditis, the same measures as in the non-pregnant patient should apply. The endocarditis prophylaxis is now only recommended according with the ESC guidelines in patients who are at the highest risk to acquire endocarditis and with the highest risk procedures. And the antibiotic prophylaxis now is not recommended as a routine during both the vaginal or the C-section. It's considered as a 3C indication. Now, in terms of the timing and the mode of delivery, the favored spontaneous onset of labor and the normal delivery in most cases of stable heart disease, but in some other cases, and here we have the indications for a C-section, and in one of them is when there is severe aortic stenosis, which is a 2A indication, so it should be considered a C-section in this set of patients. And again, this is the typical example of multidisciplinary care for the high-risk patients. For the risk stratification of the patients with cardiac disease during pregnancy, there are different classification systems. We'll look into a couple of them, like the CARPREG system, which basically look at the predictors of maternal cardiovascular events and sort of a risk score, and this risk score according with the points that either prior cardiac event, the baseline New York Heart Association functional class, presence of left heart obstruction, or reduced systemic ventricular systolic function. You get 1 point for each one of these, and the more points you get, of course, the higher the risk score and the risk estimation of cardiovascular maternal complications if you get any of these that are in this scoring system. These are considered as high-risk states with contraindications for pregnancy, and of course this needs to be discussed when there is an intention for a planned pregnancy, and it includes not only the classical pulmonary arterial hypertension, or when there is severe ventricular dysfunction or previous peripartum cardiomyopathy. If there is severe mitral stenosis or severe symptomatic aortic stenosis, this should be very well discussed with the patient, and of course these things can be planned ahead, and even the treatment can be discussed beforehand and before the pregnancy. So when we talk about stenotic and regurgitant valve disease, they have different clinical implications. The stenotic valve disease, there is a high and that's why, as we discussed a little bit, we can consider intervention during pregnancy if there is a persistence of the symptoms, and this is possible, and there are quite a few series, and I know here you have a lot of experience in this specific area, or if there is symptomatic aortic stenosis, because here there is a high risk of hemodynamic decompensation of these patients. The intervention and that's why planning is so important here, because in many of these cases the intervention should be done before pregnancy because of all the potential complications that may occur during the course of pregnancy. Regarding regurgitant valve disease, here is a little bit less complex. There is usually good prognosis, particularly if there is preserved left ventricular ejection fraction. So in most of the cases we can go through with the pregnancy with only medical therapy, and actually surgery should be avoided and should be planned afterwards. We discussed a little bit about anticoagulation. The oral anticoagulation with the vitamin K antagonist, despite some of the potential risks, are the safest therapy to prevent valve thrombosis, and they should be the therapy of choice during the second and the third trimester. And during the first one, the continuation of oral anticoagulation should be considered if the dosage that the patient keeps the INR targeted is less than 5 milligrams. Otherwise, it could be considered to switch to unfractionated or low molecular weight heparin. And then after the 36-week, oral anticoagulations will be discontinued and replaced by dose-adjusted heparin. And this is again a 1C indication. And basically here, we have now the recommendations for the management of the different conditions. For mitral stenosis, these are all class 1 indications. And again, if the patient is symptomatic, in some cases you have to do and even consider balloon valvuloplasty if that's the case during the pregnancy. If there is aortic stenosis, patients with severe aortic stenosis preferentially should be treated before, and that's why planning is so important. But in some cases, you may have to consider if there is significant hemodynamic decompensation during the pregnancy. Regurgitated lesions, we've already seen, they should be treated afterwards, and normally, if there is preserved ejection fraction, you can basically treat these patients during pregnancy with medical treatment only. These are the recommendations for anticoagulation that we've just discussed. And again, it's very important that if you can get the target INR with less than 5 milligrams, you can actually continue to use oral anticoagulation in these patients. Otherwise, you may have to shift into unfractionated heparin or low molecular heparin. There are still major gaps in evidence in these patients. One of them regards valve thrombosis and venous thrombosis. We don't have really good randomized studies. They are not easy, that's true, on anticoagulation strategies. And as we've seen, there is some controversy, although in most cases the recommendations are to, particularly if there is a prosthetic valve, to add aspirin to these patients. But we still don't have very good evidence. We saw a couple of trials with the relatively small populations. There is no big randomized trial or significant trial to demonstrate or to support the evidence to make a clear recommendation. So in conclusion, regarding valve disease and pregnancy, cardiovascular diseases are still the most frequent causes of maternal death in industrialized countries, and this is important to keep in mind. The heterogeneity of heart diseases and inherent risks